Hi, everyone. We're going to get started in just a moment. We're letting people in from the waiting room, and we'll get started shortly. Again, thanks so much for joining us. We're going to get started in just a moment. People are still coming in from the waiting room. All right, so let's go ahead and get started. I want to thank all of you for joining us today on the California End-of-Life Option Act and improvements to the law. My name is Christina Goodwin. I am the California and Hawaii Regional Advocacy Manager, and I am going to be here today with Dr. Ryan Spielvogel. To ask a question, you can just type it into the Q&A box on your screen and click send. And then we're going to try to answer as many questions as we can at the end of the presentation. I also want to point out that today's presentation is being recorded. And don't worry, you're not on camera, so you don't have to worry about that. Today, we're going to be hearing from Dr. Ryan Spielvogel, a family physician with Sutter Health, and I'd like to just give him a moment to introduce himself.
Hi, my name is Ryan Spielvogel. I am a family medicine doctor in Sacramento and medical director for End-of-Life Option Act services for Sutter Health. Thanks
so much. And like I said, I'm Christina Goodwin. I have been with Compassion and Choices for nearly 14 years and have helped, I helped pass the End-of-Life Option Act and the recent improvements to the law, as well as the Our Care, Our Choice Act in Hawaii, and I'm happy to be here today. Before we begin, Compassion and Choices is the nation's oldest, largest, and most active nonprofit working to improve care, expand options, and empower everyone to chart their own end-of-life journey. We do believe in patient-centered care where the person is in charge of making their own healthcare decisions. And before we get started, I do want to ask a polling question. Leslie, can you bring it up? And the question is, how familiar are you with medical aid in dying? We'll give people just a couple more seconds. We're at 70% participation. All right, we're going to go ahead. Leslie, can you end that poll and show the results, please? So it looks like we have somewhat familiar. We have 62% are somewhat familiar with medical aid in dying. We do have a couple people not at all familiar, and then some, I'm going to say some of our awesome supporters and volunteers are very familiar. So thank you so much for filling that out. And hopefully after today's presentation, you will be a little bit more aware of medical aid in dying. So I love this cartoon. I will say death can be difficult to talk about. And of course, nobody wants to die. But the good news is talking about it will not kill you. But it can help if you and your loved ones do plan ahead so that when the time comes, you will be ready. And with that, I'm going to turn it over to Dr. Spielvogel, who's going to tell us about medical aid in dying and how the End-of-Life Option Act works here in California.
Okay, thank you for that introduction. So medical aid in dying, what is it? It is a safe and trusted practice in which a terminally ill, medically capable adult with a prognosis of 6 months or less to live has the option to request from their doctor a prescription for medication which they can choose to self-ingest to bring about a peaceful death. What does that mean? That means somebody who has what we call capacity, so knows the difference between their options and has the ability to choose an option for themselves, somebody who is terminally ill and is going to die in the next 6 months or so, that they can choose to have this option to end their suffering ahead of time. Next slide. So the California End of Life Option Act, this went into effect in 2016. It was signed into law by Jerry Brown, as you can see him there signing this. And he was quite conflicted as a man of faith. He was conflicted about this option, and he ultimately signed it with a very personal signing statement saying, I don't know, I'm paraphrasing here, I don't know what I would choose in this situation, but I don't feel right taking away that choice from somebody else. And he signed it into law. And then Gavin Newsom recently in this past October, just a couple of months ago, signed into law SB 380, which we'll be talking about in a little bit, that will change the End of Life Option Act for the better. Next slide. So eligibility determination. So who can access this? You do have to be 18 years or older, so this is not for kids, which fortunately we don't have to deal with that often, but I have had some people ask me about that for their dying children. Resident, you have to be a resident of California. You have to have a terminal disease. So you need to be certified by a physician to have a prognosis of 6 months or less to live, which can be very tricky sometimes to determine. Physicians are notoriously bad at making this determination. So sometimes that takes quite a bit of conversations between doctors. And you have to have medical capacity to make a medical decision. If either the attending physician or the consulting physician, because this is a two-physician process, feels that there's a question about somebody's mental capacity, then you have a mental health professional weigh in and do an assessment to determine if the patient has medical capacity for this decision. They also need to be acting voluntarily. So this can't be something that their durable power of attorney chooses for them. The patient must be acting on their own behalf, and they must have the ability to self-ingest. It is notable that ingest means absorption through the GI tract. It does not mean swallow. So if somebody has a problem with swallowing or an inability to swallow, you can actually do this other ways too. So if somebody has a feeding tube inserted into their stomach, you can use that. And as kind of a last resort, you can also place a rectal tube and have the patient push the meds through the rectal tube because they can absorb it through the rectum. So ingest doesn't necessarily mean swallow. Okay, next slide. Okay, other requirements. And so a physician must inform a person about all end-of-life options. So this is a standard piece of what we call informed consent in the medical world. So a patient must be making an informed decision about any of their healthcare decisions, but it is written into the End-of-Life Option Act that a patient must be informed of all of their end-of-life options. That includes disease-directed care. Think of that like somebody who has metastatic cancer, they are still allowed to pursue chemotherapy or other kinds of options that are directed against the cancer specifically. That includes palliative care or more comfort-directed care. So saying, I've had enough of chemo, I'm going on hospice, and I'm going to be just pursuing comfort-directed care, and then medical aided dying, which you can do simultaneously with hospice. And I always emphasize this with my patients that before they reach for medical aid in dying, they should be on hospice, because whether or not you're going to do medical aid in dying for yourself, hospice is invaluable and is incredibly helpful for patients. And most of my patients, the vast majority, are on hospice and still on hospice when they choose to ingest. Patients must make 2 verbal requests, currently separated by 15 days and 1 written request. Now, the 15-day waiting period is dramatically being reduced by SB 380, which goes into effect on January 1st. And so that'll go from 15 days down to 48 hours. 2 physicians must confirm eligibility to use the law. So that's the terminology frequently used is the attending physician. That's the person that is responsible for confirming that the patient has met all of the requirements and is ultimately the person who prescribes the aid in dying drug. And then a second physician who confirms the patient's eligibility and their decision to pursue this. And then there must be 2 witnesses that attest to the voluntary nature of the individual's request, and they sign on the bottom of the patient's written request, which is a 1-page form produced by the California Department of Public Health. So that written request, the patient signs, and then at the bottom, there's a place for 2 witnesses to sign. So altogether, 2 verbal requests separated by a waiting period that's being reduced, the written 2 verbal requests, written request, and the consultant visit. Okay, next slide. So aid in dying medication is not specified in California law, specifically what we use, which has been very helpful because over the past 5 years or so, actually before that, starting in Oregon and Washington and then continuing with California, there has been a robust process in place where physicians across the country have been continuously improving the regimen that we use, so that this is now an evidence-based regimen that most physicians, medical aid in dying practitioners are using, and we're constantly improving it so that we improve patients' experience with this. So with the regimen that we are currently using, most people are asleep within 5 minutes of taking it. Everyone is asleep within 10 minutes of taking it. And about 70-ish% of people will pass within the first 30 minutes after taking it, another 25%-ish within 1 to 2 hours after taking it, and very, very few people go longer than 2 hours, and nobody goes longer than 4 hours at this point. We don't have tens of thousands or hundreds of thousands of people who have gone through this at this point, so I always instruct patients that untoward complications could arise. We can't predict everything. Just because we haven't had someone go longer than 4 hours on this particular regimen doesn't mean it can't happen. It just means it's very, very unlikely to happen. Okay, next slide. So the meds must be self-administered. So your loved one can't hold the glass to your lips and pour it into your mouth. They can't push the meds for you through a syringe. You must be the one ingesting it. The language that we tend to like is that this is a conscious, voluntary decision, and that there is a physical and conscious and self-directed act that puts the medications into the patient's body. Whether that's ingested by being swallowed or being pushed through a feeding tube or pushed through a rectal tube that is placed specifically for this purpose, it has to be the patient that is directing it until the very end. That doesn't mean that someone can't help you prepare it. So empty the capsules, that's left over from the time when we were using Seconal. Most people are not using Seconal anymore, and we're not recommending that. But it's generally the medications are they're dispensed as a powder frequently in the bottom of a big jar. And so somebody else can help prepare that, pour the water in, shake it up really well, and then hand it to the patient to drink. Or you can even, pull it up in a syringe and hand the syringe to the patient, or even hook it up for the patient, but the patient has to be the one to actually push the syringe or to actually bring it to their lips and drink it. Okay, next slide. So aid in dying is not considered suicide or assisted suicide. There is a quote that I like to read. This was a statement by the American Psychological Association that they put out in 2006. So at this point, it was only Oregon doing aid in dying. And this is what they had to say. It is important to remember that the reasoning on which a terminally ill person whose judgments are not impaired by mental disorders bases a decision to end his or her life is fundamentally different from the reasoning a clinically depressed person uses to justify suicide. This is not suicide. Patients, unfortunately, are not choosing between life and death. The vast majority of patients who are going through aid in dying wish that they could live, but they don't have that option anymore. So they're choosing the time and place for their passing, whether it's now or it's in a few weeks. And so this is a way that they can reduce their terminal suffering at the end of life, not really a way that they can choose between life and death. It is important to note that in the End of Life Option Act and preserved through SB 380 is that wills, contracts, and insurance and annuity policies are not affected by a person choosing aid in dying. And I usually like to cover this with my patients in the office because not many people think about that part of it. That what the End of Life Option Act does is it protects the patient to be able to access this way to decrease their suffering in a legal manner that is evidence-based, that we know is going to work. It protects me as the physician to be knowingly complicit in this act without putting myself in jeopardy of being liable for murder. But it also protects the family. It protects the family because sometimes wills, contracts, life insurance policies, all these kinds of things, estate transfer, probate, etc., can be affected by how someone dies if they, quote unquote, committed suicide. So SB 380 and the original End of Life Option Act say, for all intents and purposes, legally speaking, the patient died of their underlying condition. So if this person was dying of metastatic colon cancer, and that is the eligible condition under which they were able to access medical aid in dying, metastatic colon cancer is what goes on their death certificate. And for legal purposes and all intents and purposes, they died of their metastatic colon cancer. They did not die of ingestion, of overdose, of any of those things. So that's important for the patient to know. It's also important for the family to know, because oftentimes you're dealing with sons and daughters and spouses who are trying to be very supportive of their parent, but in the back of their mind, they have these nagging questions of how is this going to affect this, that, or the other thing, but they don't want to ask because they're trying to be supportive and they just don't want to bring that up. But it is something that they're worried about. So that's important to know. Okay, next slide. Voluntary participation. So just like this protects a patient's right to choose, this is an act, this is an option that is about someone's right to choose and be able to practice their autonomy as a person. There is also voluntary participation on the part of the physician and the medical organization that the physician acts as a part of. So any physician is allowed to opt out of participating if a patient asks them and they say, you know what, that's not something that I'm comfortable with, or I don't believe in that, or whatever the reason, they're allowed to opt out. Certain organizations, specifically this tends to happen with religiously affiliated medical organizations, are also allowed to opt out, which does mean that all of the physicians that operate inside of that organization are automatically opted out and can't participate. Now, if a healthcare provider is unable to or unwilling to participate, they must, as a requirement of the law, inform the patient that they are unable to participate, and they must document the date of the individual's request and transfer the records upon request. They are still not obligated under the law to refer the patient to a participating provider, but at a minimum, they must inform the patient that they're not participating. And if a physician requests their records for this, they must do that. That's part of HIPAA. They were already obligated to transfer records upon request. And it is important to note that this language was clarified in SB 380. And so this is kind of a new clarified requirement starting on January 1st. Next. Okay. So a few more things. Medical aid in dying can be taken within a healthcare facility. That was also clarified in SB 380. There was a provision in the original End of Life Option Act that is still in SB 380 that was interpreted by many healthcare facilities to say that it couldn't be, that somebody would not be allowed to ingest by law inside of a healthcare facility. But they clarified that in SB 380 that no, you can, or at least it's legal. That provision was that it's not allowed, you're not allowed to ingest in a public place. And so there was question about what does that mean and does that apply? For healthcare facilities, that does not apply. Some other things that have been added and will go into effect on January 1 is that healthcare entities are now going to be required to publish their policies about medical aid in dying on their websites. So we, Compassion and Choices, and then also the American Clinicians Academy on Medical Aid in Dying, are going to try to put together best practices and suggested language for healthcare entities for how they can publish this in a way that is not opaque and that patients can find. But there may still be an issue with patients might not know where to look to see these, but it will be very helpful, especially for instance, hospice agencies. If a patient or a patient's family are shopping around for a hospice agency in a given location, if they know that their loved one is interested in medical aid in dying, to see if the hospice is supportive and will support a patient through that process. Most are, but some don't. And so you just don't want somebody ending up, nobody wants somebody ending up at a hospice that is not going to be a right fit. The patients don't want that, and the hospices don't want that. So I think that this is going to be a win-win to have this published. And then the other big thing that is coming out of SB 380 that I know Christina is going to talk about later is that transfers of care during the process are legal. So this apparently was always the case, but was not clear in the original End of Life Option Act because it was stated that all of the requests must go to the attending physician, meaning the person that has the primary responsibility for the patient's health care and the care of the disease process that's making them eligible. And so that was interpreted by many to say all of the requests must go to the same physician, and that must be the physician that then prescribes the aid in dying drug. And this unfortunately made this be a bit of an onerous process for many patients because a patient would come to me and say, I'm here because this is what I'm wanting. I say, okay, that counts as your first verbal request. And they'd say, what do you mean this is my first verbal request? I've requested this of my hospice doctor. I've requested this of my primary care doctor and of my oncologist starting a month ago. This isn't my first request. This is my fourth request. And I'd unfortunately have to say, well, for the purposes of the law, those didn't count, and this is now your first verbal request. Well, that was not a very patient-centered way to be running business. So what what SB 380 now does is it takes it out of this physician-framed scope of practice and puts it more patient-framed. So if a patient requests it from their primary care doctor on, February 1st, and then it takes them a week to get to see me, February 1st, that request must have been documented. It had to be documented by their primary care doctor, and that counts as their first verbal request, and the clock starts. And when they see me, it's already been a week since their first verbal request. And even if they handed in their written request to a different doctor, and then that doctor went out on maternity leave, or that doctor was out of the state for whatever reason, and it falls to me to prescribe, I am able to do that under the law because transfers of care are legal in pretty much every medical process. And so SB 380 clarifies that, yes, it's the patient that matters, and it's the patient's frame of reference that matters. And so transfers of care are legal and must be honored. So that's a huge win for the patient. Okay. Having the prescription gives dying patients relief. So we know that approximately a third of patients after receiving the prescription for the aid in dying drug end up not taking it, and that's fine. There is no requirement in any of this that somebody must take the aid in dying drug once they've been prescribed it. It remains an option up until the moment that they physically take it. That is the point of no return. Up until that point, they can choose not to take it. So a lot of patients just have a lot of relief in their suffering and anxiety just knowing that it's available to them. Intent is not a requirement of the law. Okay. Next. So what if your doctor says no? Your doctor says, I'm not allowed to prescribe, or, I don't want to prescribe. Or if this is your first patient, if you're a practitioner listening right now and you don't know how to do this and somebody asks you and you just don't know what to do, you have resources. So there's the doc-to-doc consultation line through Compassion and Choices. That's the number right there on the screen. You can call our end-of-life consultation line for support. There's the number, extension 2 or extension 3. And you can ask them to refer to someone who will support you. The American Clinicians Academy on Medical Aid in Dying also has a patient intake form, and they can help match you with someone in the area. So you have a lot of resources if your doctor says no. Okay. Next slide. So to recap, you find a doctor who will help you with this process to write a prescription for you if you qualify. So if you're interested, I always tell people start this process early. If you make your first request and you kind of get your ducks lined up that you're like, okay, when I go downhill, I know that I want to use this option, but I'm not there yet, that's fine. That is a great time to start the process. Because you don't want to wait until it's potentially too late. Making a first request does not lock you in, to obligate you to have to go follow through with the process. It just gets your foot in the door and gets the process started so that when you need it, you'll be able to finish the process. I think of it like getting your permission slip. You need to get that in advance so that you can go through with this. Confirm your eligibility with a second doctor. That's part of the process. So your second request to the doctor needs to be a minimum of 15 days apart. That is still law of the land for another 3-ish weeks. And then that will drop to 48 hours starting January 1. And then to complete the process, you need to also submit a written request to your physician. And I think I'm turning it over to Christina. Oh, no. First, my experiences. So as a physician, I do have to say I never knew that I would be doing this when I was in medical school and in residency. At those times, it wasn't legal yet in California. And I honestly had not thought about this at all. It wasn't until the End-of-Life Option Act went into effect in California that the question was posed to me. And I honestly had no idea how I was going to feel about it. I didn't have an opinion one way or the other. And so I just decided, as I've done many times in medicine, in order to sort out my feelings, I just got to do it once and see how I feel about it. So I started seeing patients in July of 2016 for medical aid in dying. And it was possibly one of the most rewarding experiences I've had in medicine. And that is saying a lot. I'm a full spectrum family medicine doctor. I deliver babies. I see patients in the hospital. I do a lot of, beginning and end kind of medicine, cradle to grave. And delivering babies and medical aid in dying, I would say, have been the most rewarding experiences in my medical career. Being there and being able to very tangibly help someone who is suffering is really at its core what being a doctor is about. There is a bit of conflation that doctors have, that being a physician is about preserving life and preventing people from dying. And sometimes that's true, but oftentimes we can't prevent that because it's a little known secret, but everybody dies. And so this isn't something that we can ever prevent fully. And so owning that and allowing patients to come to terms with that and helping them in their time of need is, I think, your highest calling. Most recently, I am reminded of a patient that I just saw through the end of her process. She was dying of metastatic colon cancer and really didn't want to be able to, her functioning was declining, and she was with great difficulty able to still get up and walk around her house. And she wanted this to not progress to the point that she was totally bound to her couch and would have to be changed by her friends and family and by hospice. That was her line in the sand. So she was rapidly approaching that. And she also did not have use of her esophagus anymore due to a separate medical condition. And so she would have to have had a rectal tube placed to have the meds pushed that way. So she asked me to be present and to help with the rectal tube. And so this past Monday, a few days ago, I was able to be there for her. And she was surrounded by friends, and they got to say their goodbyes to her. And she was fully conversant and cracking jokes right up until the end. And she went out peacefully. She went to sleep within a couple of minutes of having pushed meds herself, and then was at rest within 15 minutes of having ingested the medication. So this is a enormously powerful process for patients to be able to access this, for family members too. It's not going to be unexpected. They're able to come into town and say their goodbyes to someone who's fully conversant. And then it's powerful for the physicians too. So all around, very, very powerful process, powerful option for patients who want it. And I think now I'm turning it over to Christine.
Yeah, thank you so much, Dr. Spielvogel, and thank you for supporting your patients. With that, I am going to talk about the improvements to the End of Life Option Act. I will say, the movement is growing. We now have 10 states plus Washington, D.C. that have authorized medical aid in dying. The dark blue states show which ones had legislation in 2021, and we are hopeful that we'll get a couple more states passed in the coming year. In October 2019, the California Healthcare Foundation launched a comprehensive survey. And as you can see, they asked a very specific question about the End of Life Option Act. It says, do you support or oppose people that have having this option? And it shows that 3 out of 4 Californians, 75% do support the End of Life Option Act. And this is across all demographics and the majority of every county as well in California. It may sound really challenging to get through the process, but it is possible. Every year, the California Department of Public Health releases a report on the End of Life Option Act. Last year, 262 unique physicians wrote 677 prescriptions. And of those, 435 terminally ill Californians ingested the medication. And then we have data from the first 4.5 years showing that close to 1,600 patients were enrolled in hospice and 2,858 prescriptions were written, and over 1,800 Californians used medical aid in dying. And there hasn't been a single incident of abuse or coercion. In fact, over the 20 years since medical aid in dying laws have been in place, we haven't had any abuse or coercion. What we do hear from people is that it's really challenging to get through the process. Well-intended safeguards have in fact become barriers. And we know from Kaiser Southern California, they released a study showing that nearly 1/3 of eligible terminally ill patients who would have qualified for the law were unable to survive that 15-day waiting period. And so we had SB 380, which was the improvements to the End of Life Option Act. SB 380, it was co-authored by Senator Susan Talamantes Eggman and Assembly Member Jim Wood. And like Dr. Spielvogel said, it was signed into law in October by Governor Gavin Newsom. The law does go into effect in January, on January 1st, and it does maintain the core safeguards of the End of Life Option Act. I'm going to go through the improvements. One of the major improvements is that the law reduces the mandatory minimum waiting period from 15 days to 48 hours. We found the waiting period has actually become a suffering period. And as a result, many patients were unable to get through the lengthy process. In fact, in Oregon in 2019, they have a 15-day waiting period, and they were able to, they now have a bill, a legislation that waives the 15-day waiting period if a person is expected not to survive that waiting period. And then in New Mexico, it was passed this year to where their waiting period is 48 hours from requesting the prescription to receiving the prescription. And if the physician deems that an individual will not survive that waiting period, the physician can waive that one as well. So like we said, 1/3 of individuals end up not being able to survive that 15-day waiting period. So hopefully more people will be able to access this option that they want. Another important improvement to the End of Life Option Act is that there is no longer an attestation form. This was an additional written request, and an individual was expected to fill it out 48 hours before ingesting the medication, but it was non-binding, and also the patients felt like they had gone through so many requests. They had gone through 2 oral requests, a written request. So this was just an unnecessary form. Doctors felt like it was too much paperwork. So with SB 380, we were able to get rid of the attestation form. And another improvement to the law is that it clarifies that an oral request for medical aid in dying should be dated and documented in the individual's medical record and remain valid even if transferred to another attending physician. So with this amendment, we worked with the CMA and the California Hospital Association, and these changes were made because so many patients were having to restart the process, even though they had thought they had made that first request. Another improvement is that it clarifies where you can take the medication. Dr. Spielvogel did go into, he did talk about this a little bit, and it just reminds, so the original End of Life Option Act, it said you could not take the medication in a public setting, and it just clarified that a hospital or healthcare entity is not a public setting. And if you want to take your medication in a healthcare entity, just talk to your doctor. But I will say most individuals will want to take the medication at home. And then SB 380 incorporates 3 provisions that facilitate transparency in care. It requires that healthcare entities post their policies about the End of Life Option Act on their website. And then it clarifies that healthcare entities cannot bar healthcare providers employed by them from providing truthful, accurate information and or referral when a patient has questions about medical aid in dying. And then the bill clarifies that providers who have an objection to medical aid in dying should, at a minimum, document the patient's date of request and the provider's notice of their objection in their medical record and then transfer it upon request. I know that there's been questions about the policies, and so I'm going to get into the policies a little bit. They are really important, and we do look at this from the patient perspective as well as from the healthcare and hospice perspective. So when a dying person is thinking about their end of life options, it is important for them to understand where they can go. We ask these questions to healthcare systems and hospices, and these are questions we hope everyone is very transparent about and that they put these answers on their website. So the first question is, can physicians prescribe medical aid in dying to qualified patients at your facility? And number 2, can physicians act as the second consulting at your facility or hospice? Number 3, do your physicians refer your patients to physicians who will prescribe aid in dying medication for them if they qualify? And this is a really important question, and we get asked a lot if we keep a list of doctors. We do not, for various reasons, and we really want medical aid in dying to become a standard medical care. Other organizations can assist you, like End of Life Choices California, but it is our hope that doctors who do not prescribe will at least refer them to a physician who will prescribe, and so that they can support them in that way. And number 4 is mostly for hospices. Can your staff be present when a qualified patient takes medical aid in dying? A number of hospices do not allow their hospice staff to be present, and that can be heartbreaking both for the hospice staff and for the individual who's going to ingest the medication. Maybe it might make them feel abandoned. So we encourage hospices to let their staff be present when an individual does ingest the medication. So the importance of engaged neutrality. When we talk about policies, we encourage healthcare systems and hospices to be engaged neutral. And when we say engaged, what does that mean? It means that your doctor, even if they don't want to practice this, that they will support you through the process and help you find a physician who will assist you with your request. So Compassion and Choices, we have created sample policies with procedures for the End of Life Option Act. One is for healthcare facilities and another is for hospices. We have been sending these out to healthcare systems and hospices, and they can customize it to their facility and then post those policies onto their website. I am going to show a couple of examples. Here is an example of a hospice, and this Valley Oaks Hospice is in Southern California, and they do advertise medical aid in dying on the homepage of their website. And by doing so, they let people know that they have an engaged, neutral policy so that if an individual does qualify for the law, they will then best assist them with accessing the medication. And here is a healthcare system policy. This is UCLA's webpage. They have a phone number you can call to reach a patient navigator who will then help you through the system. And I just want to say, before I get into the Compassion and Choices resources, and then we're going to get to some questions and answers, even if a healthcare system or hospice is not supportive of the End of Life Option Act, we just ask that those entities be very clear about that on their website so that somebody who is trying to access care will see that and will know what level of care they will get at that facility. So I'm going to quickly go through some resources that we have, and we can send these out to you after this webinar. Dr. Spielvogel did talk about our end of life consultation line, where you can call and get support. And also we have our compassionandchoices.org/California webpage, and we are in the process of updating materials to reflect the changes to the law. And you can also find the 13-step process for accessing the medical aid in dying medication on our website. We are in the process of updating our End of Life Option Act brochure, which is available in English, Spanish, and Mandarin. I look forward to the day when I don't have to talk about our COVID-19 toolkit, but we do have one on our website. It's in English and Spanish, and you can, there is an addendum for your advanced healthcare directive in case of contracting COVID. We do offer free presentations for any organizations that you're affiliated with, churches, service organizations. We can come to you in person or via Zoom and can talk about advanced healthcare planning, preparing for dementia, and end of life options. We do have a Find a Partner Doctor resource, and it can help you ensure that your doctor is on your side and in alignment with your values and priorities. And then Dr. Spielvogel did talk about our doc-to-doc consultation line. So if a doctor, if you talk to them and they want more information, you can let them know that there is a toll-free number they can call to get more information from physicians who have prescribed medical aid in dying. Let's see, December 16th to 18th, coming up next week. We are working with the City of Hope for their annual clinical end of life symposium. It's going to be in Las Vegas next week, and they are offering it virtually as well. You can go to cme.cityofhope.org for more information. It's a great opportunity for medical providers to learn more about medical aid in dying. We have various social media accounts if you want to follow us. And then also Compassion and Choices is funded, exclusively, almost exclusively by our donors. If you have capacity and if you want to donate today, go to compassionandchoices.org/donate. And with that, I'm going to stop screen sharing. And I know we have a lot of questions, so let's go ahead and get to those. So Ryan, does a physician need a special certification or training to be the primary MD in the process?
No. Ideally, they have some training in it, but this is why it's important for organizations to have some dedicated trainers within the organization, or at the very least to reach out to Compassion and Choices Talk to Doc line or ACA MAID to get training in that. But no, there's no special residency training or anything like that.
All right, and then there's a question, can a witness be a family member? So this is for the written request, and there's two witnesses on that written request. One of them can be a family member, but only one of them can. Do you want to add to that, Dr. Spielvogel?
Yeah, sure. So the point of the witnesses and why they tell you who can and can't be a witness is they're trying to eliminate or decrease the possibility of coercion to make sure that the patient is acting voluntarily. So they limit the witnesses and say a maximum of one of them can be a family member and a maximum of one of them can be a healthcare provider working on their case. And neither of the witnesses can be either the attending physician or the consulting physician. So, a daughter and your neighbor or something like that, it's frequently some combination like that.
Okay. And then another question. So a patient has esophageal cancer, had a stent installed, and cannot eat, drink, or swallow. He wants end of life option. How can he access, or how can he ingest, or she ingest the medication?
Right. I think I addressed this. So that's done via a rectal tube. It would be by far the best way to do that. If the patient does not have a feeding tube, if he or she has a feeding tube in place, placed into the stomach, then they can access that directly. But otherwise, for the purposes of aid in dying, you can place a rectal tube at the time of ingestion for them to use.
Okay. And then I have another question for you. We had a patient at our hospice who lived 8 hours, and then we put her on palliative sedation to ensure she continued with relief from suffering. She passed away 3 days after ingesting the medication. I know you say you haven't experienced someone living very long after, but what would you say happened in this case? Patient did not ingest fast enough, tolerance to the orders?
Yeah, so hard to say. I don't know what regimen they used. And there is a long list of what we call red flag factors. So every case is different, every person's body is different. And so it's our job as medical aid in dying practitioners to know the patient's history and make sure that we know if they have risk factors for a prolonged death. Sometimes that can't be avoided, but it's helpful to know ahead of time. Also, I didn't say I've never had a patient go long. I said I've never had a patient go long on this regimen. So the most recent, I'd say 2 iterations of the evidence-based regimen that we're using them because we have significantly improved time from ingestion to death. Some of the older regimens that we were using 4, 5, 6 years ago did have that problem where they worked great most of the time, but occasionally we had someone go really long. And that's never a great thing to happen for the patients, for the family, for the physicians taking care of them, for anybody. So that is why this process improvement process is in place for us to now have a regimen that works really well and works for everyone.
Thank you. This question is, can your organization help in finding participating providers? So we did talk about this a little bit. Compassion and Choices does not maintain a list. We used to a long time ago in Oregon, and what we ended up finding is that physicians would just refer their patients to the people on the list and not even consider being the attending or consulting. And so instead, what we try to do is do more education around it in the hopes that that medical aid in dying will become standard medical care. There are organizations in California that do maintain lists, and one of them is End of Life Choices California. We also have on our website the Find Care tool, and it will help you find hospices or healthcare systems that may have supportive policies. And you could just Google Compassion and Choices Find Care tool. So Dr. Spielvogel, what is the current medication regimen?
Okay, so the current medication regimen is a combination of multiple medications that we use for other things. So this is currently a 5-drug cocktail that includes very, very, very high doses of morphine, diazepam, otherwise known as Valium, amitriptyline, digoxin, and phenobarbital. So these are all designed to sedate somebody, make them go to sleep, and to end their bodily functions.
Okay, there's a question, will the recording be available afterwards? And we will definitely be sending this out. It'll go out in that follow-up email with our resources that we talked about. This is a really big one. I know there is some concern about the 48-hour waiting period and this expectation that everybody has to get through in 48 hours. So the question is suggestions on how to message to patients and manage patient expectations that staff and doctors will try to honor the 48-hour waiting period, but the wait may exceed 48 hours.
Yeah, there is a robust conversation going on right now among the medical aid and dying practitioners in California and beyond about how this is going to work. The way that I think about it is this. The original End-of-Life Option Act was pretty inflexible in terms of its timeline, meaning that many patients were planning ahead. They were coming to us saying, I don't plan on ingesting in the next month, maybe 2 months, maybe 3 months, not really sure. I'll see when I decline. Great. 15-day waiting period works really great for that. But there were a lot of patients, there still are a lot of patients who come to us actively suffering, actively dying. We know when we see them that they're not going to make it through the 15-day waiting period, or they might make it through the 15-day waiting period, but they are really, really suffering and want this now. What the 48-hour waiting period does is it builds new flexibility into the law where there previously was none. So somebody who is actively dying, somebody who is significantly suffering right now, we are able to legally expedite the process for that person. So previously we weren't able to do that. Now we can for those select patients who really need it. And of course, that's subjective when I say need it. But it's going to be a case-by-case basis. But I don't think that it's reasonable to assume that every patient going through is now going to have the process fully done in 48 hours. I don't think that's going to happen. And I think that it's really got to be messaged from the provider and done on a case-by-case basis that this is, someone who needs the process expedited, we can expedite the process. Someone who doesn't, we probably will see that patient back in a week, 2 weeks, because the physician also does need to be comfortable with the case and make sure that they are comfortable prescribing in somebody's individual circumstance. So it doesn't mean everybody, the whole process is going to be done in 48 hours for everybody. That's not what it means. It just means previously inflexible, now flexible.
Okay, there are so many questions. We may not get to all of these. You can always email cgoodwin@compassionandchoices.org. And if we don't get to your question, I can be sure to respond to these as well. There is a question about posting policies on the healthcare systems and hospice websites. Must it be the actual policy, or can it just be a statement indicating that we participate in information and resources about how to proceed? So the law does not specify what the policy needs to look like, what it should say. I will say that the questions that I reviewed during the presentation, I think will give people a really good sense of how engaged and/or supportive that healthcare system or hospice will be. Really, the goal of posting policies on websites is for transparency purposes and just assisting individuals with accessing care. Ryan, I think this is a good question, and I know we're running out of time. What if you have a 6-month diagnosis, but still want to continue chemo or clinical trials, but also want to have medical aid in dying available if it's too much pain? Is that possible?
Yes. So this is this is where hospice and medical aid in dying differ a little bit. And that's because of kind of where the funding from hospice comes from. You can't be on hospice and receiving hospice services while still getting chemotherapy. That just has to do with when you go on to hospice and you access the hospice Medicare benefit, you are basically relinquishing your other Medicare benefits. Medical aid in dying does not have any such financial pieces to it that prohibit its use based on payer or based on your other treatments that you're pursuing. It is solely based on you having capacity to make this decision for yourself and you having a prognosis of 6 months or less. So if you have those and you come to me and say, I'm not ready to go just yet, I am still involved in palliative chemo and palliative radiation, that's fine by me. You are asking for this option to access it and you have the prognosis and therefore you qualify. And that counts as your first verbal request. You may choose to go all the way through the process and do the written request, consultant visit, second verbal request, et cetera, and say, I'm not ready to take it yet. I will let you know when I am. And in the meantime, I'm still going to be doing palliative chemo and radiation. And I say, great. And I'll generally check in with you every month or so to see how you're doing and where you're at. And when you say, all right, it's time, then I will write the prescription right then and there because the process is, you've already completed all the requirements and you can get the medication sent to you the next day and you can do it when that time has come. So there's no requirements that you have given up. Again, this is one option. It doesn't mean that you have to have ceased all of your other options at that point.
Well, we are a little bit over time. We have an abundance of questions still to go through. What we can do is we will go through them and we'll include them, we'll answer them and include them in our follow-up email to everyone that attended today. Dr. Spielvogel, I want to thank you so much for your time and for everyone that joined us. And, please reach out to us. We are here to support you and have a great day, everyone. Thank you.